So good morning, good afternoon, and good evening. I would like to welcome you all to the fourth Bridge to Life webinar of our ILTS, DCD, and machine perfusion special interest group. My name is Marit Kalesvaart, and I'm one of the topic coordinators of this SIG from the University Hospital of Zurich, Switzerland. And I'm moderating this webinar today with Wojtek Polak, who is also a member of the SIG steering committee. And he is an HPB and liver transplant surgeon, and also the surgical program leader of the liver transplant program at the Erasmus Medical Center in Rotterdam in the Netherlands. He's also the current chair of the ESOT of ELITA, the European Liver and Intestine Transplant Association. So today we have an exciting program for you, where we have three presenters, Andrea Schlegel, Amelia Hesheimer, and Christopher Krum, discussing the most important statements and recommendations of on DCD from the ILTS Venice consensus meeting that we held last year in Venice. And 4 working groups have written their manuscript that was all discussed at this consensus meeting, and these manuscripts are undergoing revision right now at the Transplantation Journal, and the working group on regulations in DCD and procurement surgery is already published in Transplantation. So for all the attendees, we have 3 presentations today, and important for you is that you can put your questions on the right in the Q&A box, and then we as moderators will answer the questions for you for every presentation to the presenters. So now I would like to give the word to Wojtek to introduce our first speaker. But before that, I would like to thank Bridge to Life again for their sponsorship of this series of webinars. Thank you.
Thank you very much, Marit. It's a pleasure to be here. Last time we met almost 1 year together face-to-face in Venice for this consensus conference. So today we have a synopsis of these guidelines, as Marit mentioned. And the first speaker is Andrea Schlegel. She's trained in Zurich, Birmingham. She's certified transplant and HBP surgeon, currently working at the Cregi University Hospital in Florence. She's mostly interested in protective mechanism of novel machine perfusion techniques, but of course also in risk assessment in liver transplantation, especially use of extended criteria donors, and of course DCDs. So she's the right person for this first topic, which is donor and recipient selection and complication in DCD. Andrea, the floor is yours.
Thank you, Wojtek, for the kind introduction, and thanks for the invitation and having me. It's a great pleasure. It was already more than a year now that we met, and I still think back with very nice thoughts of all the teams, and we've been working greatly together. I have nothing to disclose, and I just introduce a little bit what we've done during this consensus conference. As in any consensus conference, there was an organizing committee, as Marit shortly introduced, and we had expert groups which were meeting and preparing, of course, the meeting. And after literature review, we designed and proposed the recommendations. In our group, it was, for example, risk factors for donor and recipient. Other groups looked at outcomes or machine perfusion, and then we discussed that with the attendees, and the final recommendations were presented and based on the grade system. I'm sure you're all aware of this system. I will not go into details, but you can see that, of course, in the literature. And our dilemma is that we have very rarely high-quality randomized controlled trials. So most of the statements were classified E or 2A or B or even C. When we look at the literature in PubMed in the last 15, 16 years, you can pin it down to about 550 papers on DCD liver transplantation, majority in the last 10 years, and we did the consensus meeting in January 2020, and this included 15,000 controlled DCD type 3 transplants published, and ranged between 25 and 3,200 cases in single centers or registries. I will go a little bit through the results, as I've been asked to talk about complications and early allograft dysfunction a little bit, and then try to explain how we can achieve the avoidance of these complications with donor and recipient selection and the tools we have and what our group has suggested during the meeting. Just shortly, all organ procurement, organ donation, we are somewhere between life and death, and we hope to catch the organs in a status, a metabolic status, where we can still recover. And we have basically three areas. Most of us are all aware when the risk is too high and when it is low, and the majority of cases is somewhere in between. And it's quite difficult sometimes to catch the combination, the right combination of donor and recipient to have acceptable and good outcomes. And this is mainly based on that we do not really know what is the pre-injury in the donor, in the organ with warm ischemia, and all the injury the donor brings along, and how can we assess it, which is quite difficult. Graft survival, when you look at this paper from Chris Crome, can be presented like that, and then you don't see much difference. These were 300 DBDs and 300 DCD transplants, and this is very much in line with the best possible outcome in DBD liver transplantation. And we could say, yeah, what shall I improve? What can I select better? But of course, in the outcome group, you always find a sub-cohort which suffers terrible complications, and not only biliary, but also other complications we are afraid of in this cohort. Here is just an example with ischemic cholangiopathy, which is reported in a large range between almost no complications or no ischemic cholangiopathies to 30, 40, and 55%. And there's a meta-analysis from O'Neill, already 7 years old now, including 25 studies. And if you compare that to what we can achieve with DBD transplants, we know that BNF and HAT is consistently low and comparable. The overall biliary complications, mainly driven also by anastomotic strictures, are somewhat comparable with a big range. And the non-anastomotic, as seen on the previous slide, are significantly more, as we all know. And the problem, or another issue here, is of course that mainly earlier studies were on one hand not able to define clearly what are we looking at. So it's difficult to predict something you cannot specifically define. And then there's a lack of factors or risk factors, which is in some studies reported, in others not. And I just wanted to pin that down for you to understand what we have been looking at and what we tried what Jungle tried to go through. Some co-authors report donor age as a risk factor, others donor weight. Then you have difficult or different thresholds, 60 years, 50 years, 8 hours cold storage, 40 years. And we tried to make our way through this jungle of risk factors to find the right recommendations. And this is a summary published in the DCD book by a few of our colleagues. And you see the problem. All complications are reported in a range in the last 10 years. For example, acute kidney injury is a bit more than 10% until 80%. Of course, always depending on the risk of donor and recipient. Rejection has a similar picture, cholangiopathy, and so on. And there's no uniform assessment yet, and it's always a combination of risk factors. The early allograft dysfunction is also playing into this. And we all know the OTOF classification, which is the most well-known and well-accepted, based initially on 300 graft. It is 11 years old now, and we all know it mainly includes AST and ALT above 2000, and it has a link to outcomes, patient survival, and other risk factors. And it is also externally validated. But the problem of all these models, it's not specific for DCDs, and is also not really validated in our DCD cohort. And that led to a few problems. And one patient group is fairly under-assessed until recently. The Italians have took 2,000 liver transplant cases in a mix DBD and DCDs, and they tried to identify those who do not have a primary non-function, but who develop then a need for an early liver retransplant. So it's of course an EAD, which then most patients change or they modify into insect status and have long ICU stays with infection, sepsis, rejections, and need an early retransplant. They have summarized risk factors to identify those. And now the question is, how can we balance donor and recipient risk, or what can we do to avoid all these complications with the donor and the recipient we have? And here, this slide shows a few of these factors. Of course, age, steatosis, cold ischemia are listed. Warm ischemia will be covered by Amelia in the next presentation, and the recipient brings a lot of potential risk factors too, which are not so often considered in the papers. And you have a few special situations we have to look at and to decide if we want to give a DCD graft, for example, to someone who requires a retransplant or not. And the reality is the tools, if we want to call it like that, are very scarce. And one very important tool is, of course, clinical experience. And if I get an offer, let's say a 72-year-old donor, I may accept it if warm and cold ischemia time is short, and if I can choose a good recipient with or without the use of prediction scores. And if I know my colleague who does the procurement, and I can tell him, yeah, please be quick and flush and all the tricks I have, and maybe I know a friend in another center who would accept it under all these circumstances. But that is more or less our train of thought and the reality we are dealing with. The general statement, before starting with the specific ones, is of course all our suggestions by the ILTS group and the consensus meeting are in context of controlled DCDs and the literature, and we wanted to provide guidelines for also smaller centers or countries who want to initiate a DCD program. It's all in context, at least the first 4 statement group presentations in context of cold storage, so standard, super rapid retrieval, and cold storage preservation. And it has always to be considered in context of the local regulations, acceptable outcomes in regions and countries, and the waiting list mortality. For donor age, for example, we look at the first one. It's interesting because 10 years ago, there are papers you find that suggest to accept donors only until 40. And if I remember, when we started in Zurich, the DCD program in 2011, we said 40 years and not more, but we wouldn't have any donor. So recently you can find thresholds like 50 years, 60 years, 70. The recent publication from the King's College, it's a national data set from the UK. And you see the numbers, it's actually very limited, 70 DCD livers above 70 years, and 93 in the other paper from Birmingham above 60. But you can select the cases, you can avoid additional risk factors, and you can transplant this by experienced centers. Just here, one example, and it's everywhere similar. It's mainly the King's College in London and Birmingham who did the national cohort in the UK. And you can see then the graft survival. And the 70 years group, if you want to say, okay, 5 years might be interesting, afterwards it's getting thinner and the numbers are low. But you can see those recipients have a similar outcome. Interesting. And to present the first statement, we suggested, and many countries have already this general cut of saying up to 60 years donor age, we would accept the DCD livers. And if we get beyond 60, we should be selective, and then it's already getting gray. And depends very much on the experience and what we want. And centers, again, to remind you, it's all in context of cold storage, but centers with the ability to use machine perfusion routinely. For example, in Zurich, we take any DCD liver and we put it on the machine. Last Friday, we did 82 years with 35 minutes functional warm ischemia time, and then we just assess it and transplant it. So it's all in context of the individual experience and regulations. The donor BMI is similar and has an impact not only on the steatosis we're all afraid of, kind of, but it has also an impact on the retrieval time, the time to cannulate, time for hepatectomy, and steatotic livers simply cool down slower than non-steatotic livers. And in the literature, we frequently read, BMI above 40 is declined and not accepted in general, although there are papers like the one from Maturian saying it's not automatically that patient with a BMI from the bariatric cohort, for example, a BMI of more than 40 has a steatotic liver. We know we get more biliary complications and acute kidney injury, and also we have seen in the literature more graft loss if we are in combination with a higher donor age. And looking at the overall picture of the literature, we have suggested that we should say, okay, until a BMI of 30, we should take the liver initially. And if we are above 30, we would again combine it with the same risk factors: age, warm ischemia, steatosis, donor hospital stay, other parameters like liver function tests, hepatectomy time, and cold storage time. And in general, I would like to say, look at the liver. I had offers, and we all had offers above BMI 40, 45, 50, and suddenly the liver is not fatty. Steatosis is the next topic, and I'll just go shortly because the data in DCD is not so frequently available. You see a few examples on top, and you see already that those very fatty ones are often not retrieved. And those were DBDs, the piece of butter on the right side, and the second one as well. We know that microsteatosis is of less relevance, and that macrosteatosis above 25, 30, and higher percent may have higher biliary complications and even a very higher ischemic cholangiopathy. Those two graphs are from the steatosis and the Barscope paper, and you see the lowest donor-recipient risk combination has already an impaired graft survival if we have more than 30% macrosteatosis. And in DCD, there's one paper which was published last year by the group from the Mayo Clinic in Florida, and you see that they have looked at the data with the steatosis, so the available biopsies, and you see it took 20 years to have 26 grafts with moderate steatosis and DCD. And then you have the other two groups, mild and no steatosis, of course, and you see the other risk factors are low. And despite this, if you have a moderate macrosteatosis above 30% equally, you have all the complications you don't want. You get perfusion syndrome, cardiac arrest, higher rate of PNF, EAD, kidney failure, and so on. And we know this, and we're afraid of this high morbidity. And based on the literature and what we've seen before, we would suggest, of course, to avoid macrosteatosis and DCD grafts with a percentage of more than 30, mainly also in the absence of machine perfusion, because we want to assess and see the impact of this technology. And this is all, again, in context of cold storage. Cold ischemia time is very similar. Loads of papers, case series have looked at different thresholds from 4 hours to 12 hours. There's also a threshold of 10 hours suggested. But if we look at the combinations with donor risk and warm ischemia time, we all know that each additional hour of cold storage increases the risk for graft failure, and this is mainly due to the lack of energy, as you see here, and the accumulation of succinate with subsequent higher rates of reperfusion injury. And you give a short look to the median times. Most series published have a median cold storage of 5, 6, 7, some 8 hours. And if we summarize that, we would suggest, of course, to be as quick as possible. So cold storage as short as possible is good in DCDs, as in steatotic livers. And we suggest that it should be within 8 hours, ideally. And if we get beyond 8 hours, again, we need to consider the other risk factors. If everything else is beautiful, you may get through nicely, even with longer than 8 hours, even with longer than 10 hours, but it's an individual decision. Equally, we would recommend not to use any DCD liver with cold storage, without machine perfusion, with a longer cold storage than 12 hours. Recipient risk, very often under-evaluated. It is fairly unclear if a sick recipient with a high MELD, for example, or ICU retransplant is able to handle the reperfusion phase, which is, of course, depicted by a higher reperfusion syndrome, post-reperfusion syndrome with potassium and potential cardiac arrest, and we simply don't know. So at some point, we need to say, no, this recipient is too sick, but which one? And a few factors contribute. One is recipient age. There is an inferior 5-year survival of 10 to 20% when we compare it to younger recipients in DBD transplants. And we know all that you have a higher risk for cardiovascular events, coronary artery disease, for example. And we also know that this age plays an important role if you combine it with higher donor age and other risk factors. But overall, the specific recommendations in the literature are very limited. There's only one group suggested at the recipient age cut off 55 years. And in the end, it depends on the center or region or the country. And it's an individual decision which recipient should be transplanted anyway, in general, until what age. Some centers have 70, some centers, I remember Birmingham, we have 70, and then we say, oh, yeah, but we have done a few older than this when they are fit. So we do it, and then we select the graft already in the MDT. In general, we would recommend not to use a specific recipient cutoff. It's individual, either high or low. And we also discussed the use of DCD donor livers in pediatric recipients, and the literature is about 60-70 cases reported from the UNOS database and from King's College, for example. And overall, we would say we can use it selectively with a very limited donor risk, and rather in elderly children. For example, the UNOS cohort has a median recipient age of 7.7 years, and most of those grafts transplanted in UNOS were whole grafts, and only 3 left lateral segments. The same picture for the MELT. We all know MELT increases with each point, potentially increases the comorbidity, and we do MELT40s with good grafts today. Majority of literature in DCD setting has a MELT of less than 20. Specific data for cutoffs are lacking. Instinctively, we always allocate DCD livers with higher the risk to a good recipient, HCC, for example, and 2 papers who try to develop score models suggested a cutoff of 25, and that's what we adopted for now, and said, okay, we would suggest the routine use of DCD for candidates in context of the overall risk with a lab MELT of 25, and would be very careful if you have, of course, DCD donors in combination with a higher MELT, although we know MELT alone is, as any other risk factor, not the main thing. BMI, the literature gets more scarce here. We know most things from the DVD transplants again. We have a decreased 5-year survival there when the recipient BMI is higher than 30, 35, and we know that we may have a prolonged hepatectomy and implantation time, which may lead to a longer secondary warm ischemia time with more reperfusion injury and more complications potentially. A few cutoffs softly reported with 25 and 30. We know that we get more kidney injury in a prolonged hospital stay related to the kidney and infections, for example. But the problem with the BMI is also that it's very affected by co-founders. For example, ascites is the best factor, and the higher morbidity may also come from the related kidney dysfunction prior to transplant, so it's not so clear. Overall, we suggested not to recommend a specific cutoff for BMI in DCD livers. NASH is getting better. We all know the metabolic disease and malignoma will increase, and in the future even further. It's already #1, and instinctively, if I see a NASH candidate like on the picture, I would love to say no at all, not only to DCDs, and we're aware of most risk factors which are listed here, but the data is very, very limited. And in summary, we would suggest, of course, as always, we are looking in any NASH recipient, we are listing very specifically on the cardiovascular risk and the overall medical risk, and we do a physiotherapy program and diet program before transplant if possible to prepare those candidates to be as fit as they can. And of course, we would select DCD donors selectively or combine them selectively with NASH. The other underlying diseases are usually mixed in all the retrospective cohort studies we have, and all do well. There's no really a difference assessed. When we have revert to the cholestatic diseases or primary sclerosing cholangitis, we can say there are reports which show comparable outcomes, even with Roux-en-Y. Others earlier have reported a higher risk for ischemic cholangiopathy, but experienced centers with a lot of PSC patients will argue and say we need DCDs because those candidates first can handle the post-reperfusion phase very well. They are usually young and fit, and they are at risk to get a cholangiocarcinoma, so we have to give them a liver. And so we have suggested to keep that PSC as an indication. The other factor or other underlying disease is HCC, and there you see there are more studies in the literature with DCD and DBD found, and it's a bit, they're both results to be seen. Some reports say, okay, we have a higher risk in DCD and a higher recurrence rate, which is linked to the ischemia mechanistically through reperfusion injury and immune system activation and the nice niche you create in a higher risk organ for those cells to resettle and regrow, as Kwan has shown. And others have saying you have a good DCD organ and you can achieve similar outcomes. In general, we need DCD livers for HCC recipients, and we would not list any of those diseases like PSC, PBC, or HCC as a contraindication, as recommended by the panel and the ILTS. Another few specific conditions, similar acute failure, portal vein thrombosis. It's in the end all an individual decision. With the same reason, you have a narrow window for opportunities for acute failures, and it always depends, for example, on the cardiovascular stability and the brain function, if you really want to give it DCD and try, and the center policy, of course. And similar features are found with portal vein thrombosis. I think we all fairly agree that a complex portal vein thrombosis we would not list with the option to get a DCD graft, but probably grade 1 or maybe grade 2 could be done. And the risk is, of course, to prolong the cold storage and then all the reperfusion injury and complications. And it is also an entity to be seen in context of machine perfusion in the future, where probably we can safely use these DCD livers with a bit longer cold storage or when they sit on the pump. The other example is retransplantation. We all know retransplant recipients have a higher risk for complications by nature, vascular and all the potential complications. And there's one paper by the group from Rotterdam. This is one of the main reports with 21 DCD grafts, and it's basically a selection. As you see, the risk factors and the timings and the etiology why those candidates received a regraft, and also the time between first graft and retransplant, you see it's basically a selection. And if you select properly, you can achieve a good outcome, as in all the situations. And looking at the outcome graph here for the graft survival, you see the first 1 to 2 years, you can probably use that, and afterwards you have a low number, of course, because the follow-up is not long enough. Overall, we would say all these specific conditions, we would be very selectively in giving DCD livers for retransplant for acute failure, super urgent, or also for cases with previous complex upper abdominal surgery. And routinely, we would not recommend to use DCD grafts for complex portal vein thrombosis. But otherwise, maybe yes. The last point here is now the combination of liver and kidney transplants. You see it nicely. This is the paper from Chris Chrome, and they have assessed 2 eras, before and after 2010. You see that after 2010, the numbers have increased, and also the outcome has improved from 50 to 75% survival in 5 years. And overall, if you can select liver and kidney according to the criteria published, you can successfully use those grafts also in combination and even without machine perfusion. Some put the kidney routinely on the pump and implant the liver quickly, and I think many variations are feasible. So we say again, selective use for the combined liver-kidney program and DCD grafts. Score models have many problems. This is just to show you what is available for DCD livers, and you have 3 scores with donor risk factors only and 3 with the combination, and overall they have all similar problems. This is the donor liver index. You see the highest risk group here, encircled with red, has a 5-year graft survival of more than 80%. So this is difficult if I want to really identify those cases which are lost initially. I think all the scores have similar issues. You see the King's College DCD risk index here discriminates fairly nicely, but the middle group or intermediate standard risk group has the highest number of grafts, and I'm sure there are some within this group which do worse than others, and also the UK DCD risk score has similar features. You see that this is the Framingham scheme, and you can add and balance the points, but the shortcoming of all scores are they do not really account for additional risk factors, and they have to be available in the registries, and they're always related to the risk distribution and acceptable outcome in the region where they were developed. So overall, we said, yes, they can help us. Score models help us to evaluate the risk, also to report the risk, to compare risks in cohorts in different publications, and it might be useful to define thresholds when to say no to a certain risk combination, and maybe to say this graft I should do perfusion, and this graft, I should have a different recipient. In summary, in the paper, the risk factors will be summarized like this here. You will see donor recipient risk and prediction models. And I would like to thank everyone in the working groups and also in my working group, also in Tanner, who was my co-leader of this group, and all the other participants. We had a good discussion, had a nice time, and I would like to thank you for your attention and happy to take all the questions.
Thank you, Andrea. Thank you very much. Very clear and very comprehensive summary of these recommendations. I have two questions from the audience, but I would like to start discussion with you, asking, you said that basically we can a little bit push the limit by selection of the patients using machine perfusion. Of course, the recently DHOPE trial has been published in New England Journal of Medicine. So basically what we will do in the Netherlands, every DCD will be put on the pump, the same as you do in Zurich. Then basically the fear of prolonged cold ischemia is gone. So maybe you can use it quite safely for retransplantation basically, or for portal vein thrombosis. What is your opinion on this?
Thank you. I think that's exactly what we all think. We are very happy that this trial has been published, and that we have something also to explain to our commissioners. We want now every organ to be pumped, as they do in Italy. Every DCD goes to NRP, cold storage, and HOPE. And you see they have quite long cold storage in the middle, 10 hours, sometimes even 12 hours, and they do well with almost no biliary complications. So I think that's the way. And also the other risk factors. In Switzerland, we have no donor age cutoff anymore, because again, 80 years can be a beautiful liver if you have nothing else. And the second factor which contributes here as well is probably the viability assessment, where we will get more information if we can do it or not. But this needs time and we need more data.
Yeah, absolutely. But let's say for the standard DCD, what we call good DCD, well, the pump should be, cold pump should be efficient enough to put it, to extend the criteria for by the recipient at least. So I will go to the question. First question came from Dr. Mulligan. Is it critical to use machine perfusion to successfully use older DCD liver? If so, normothermic or hypothermic?
Well, I'm a hypothermic person. I did a lot of normothermic in the lab and different studies. Practically what we've seen, if you have a good liver, good DCD liver, as we know, we can do it with cold storage when we limit the risk. We can put it on the pump if we really have to, logistically, if that's our policy. But to improve the metabolic situation, when we look at the mechanism, I would put it cold initially. So I know the colleagues from Groningen and also experimentally from Birmingham have done a rewarming to assess it during normothermic perfusion, because we still have to confirm and validate the viability parameters. But with the cold perfusion, we know in all organs we can improve the metabolic situation. It's published in all transplant solid organs now that we can really safely improve that, and that's cheap. And it works clinically. We get more and more evidence, also looking at the other upcoming randomized trials. So I'm sorry, but I think it will be, for me, it will be cold.
Thank you. The next question is from King's group, from Dr. Yassan. After 20 years of DCD, I understand that we are still conservative. Any recommendation for pushing the boundaries?
I think you did a great job describing the impact of the retrieval surgery and all these things. But even with the quickest retrieval and the best flush and the shortest cold storage, there are organs which are metabolically not favorable. Or donors bring something and you just have that risk, and you have the cells and all this, what we see after reperfusion. So we come back to the perfusion. So we have to change the cold storage in the end. Perfusion system.
Okay, thank you. The next question is from Warsaw, from Dr. Domagawa. Do you think that MP, Do you think that MP or NRP should be recommended in order to use DCD liver grafts in general? So if you use DCD grafts, you should use either or a machine perfusion or NRP.
I think that's where we're going to, with bigger steps now, with the randomized trial and what we see. Look at Italy; it's compulsory. It's obligatory. You do NRP and HOPE.
Yeah, the same for France, same for Norway. So I think this is the way we go.
Yeah.
Okay, the next question is from Marina Berenguer. What is the most important, the donor-related or the recipient-related risk factor? This may have impact in obtaining consent prior to waitlisting for the patient for DCD.
That's a good question, and that's also what we learned from the scores, that you need to balance it, and I think both are very important. The more experience you have, you know which recipient you can get through with, which donor. And what we did, we always consent when we decide as a team, for example, in the MDT, we say we can give this recipient a DCD, then we consent for that automatically before at listing.
Well, we are not consenting our recipients for DCD or DBD. That's, let's say, a decision of the surgeon together with the hepatologist. But I can imagine that in many countries it is well consented. Yeah,
we just keep the door open. So we inform the patient for both and then explain what it is when we get there.
Okay, the next question is from Dr. Rosano from Mexico. Do you systematically evaluate by ultrasound the liver status of the donor pre-procurement? So
that depends very much on the regulations of the country. In the UK, we rarely did any assessment in the donors. So ultrasound you don't get. In Switzerland, you get it frequently. You get an ultrasound almost always. Then you can a bit estimate fats, yes, no. Depends very much. If you have the opportunity in your country, it will certainly help.
I would do so, definitely. And in fact, within the Eurotransplant, there is now the project to do the CT scan in every donor, not only in DCD, just to get much more information on the donor side. There is another question. Wait a moment. That's more or less the same. In DCD liver transplantation, we now mainly use non-machine perfusion. Clinical results can be good. Machine perfusion application can be better. That's very similar to, this is from Dr. Liu, but very similar question from Dr. Puri. So what do you think? Do we better with the machine, or can we still compare?
We all have seen recipients who go home after 5 days with a DCD liver, and you have the opposite DBD for 4 weeks, 6 weeks, 8 weeks. So, but I think what we've seen in experimental studies and also in our cancer assessment, also HCC recurrence, you can always improve something. So I think even if you have we had an experimental study, 1 hour cold storage, and you do this HOPE or cold perfusion in that time, you can prevent immune activation, you can improve something. So you don't, and it's not so expensive, you don't lose anything.
Absolutely, I totally agree, and I support machine perfusion especially in the DCD population. Okay, Andrea, thank you very much for answering these questions, and I think we have to move on to the next presentation. Marit, can you introduce the next speaker, please?
Yes, so I'm introducing a second speaker of today, Amelia Hesheimer, who is also one of the topic coordinators of our DCD and machine perfusion SIG. Amelia is a specialist in HBB surgery and liver transplantation at the hospital clinic in Barcelona in Spain, and our clinical work and research both focuses on DCD, perfusion technologies, and transplantation of partial liver grafts. And she will present to us the recommendations and statements formulated from the consensus meeting on regulations and procurement surgery in DCD, including the use of NRP, normothermic regional perfusion, also donor warm ischemia time. Amelia?
Good afternoon. I'd like to thank the ILTS and Bridge to Life for the opportunity to present today some of the findings of the 2020 consensus meeting on DCD. In particular, I'm going to focus on regulations of procurement surgery in DCD. My name is Amelia Hesheimer. I'm a surgeon in Barcelona. These are my conflicts of interest. So I was primarily involved in the DCD consensus meeting in Working Group 4, which was tasked with evaluating regulations of procurement surgery in DCD. My fellow working group members were Wojciech Polak from the Netherlands, Corinne Antoine and Federica Dondero from France, Daniel Malou from the United States, Diet Hartman-Ballieu from Belgium, and Gabriel Aniscu from the UK. In terms of my presentation today, I'm going to again focus on regulations and procurement surgery in DCD. I will provide some brief comment on functional warm ischemia, which was the primary focus of Working Group 1. I will then overview technical considerations related to DC liver retrieval using both supra recovery and normothermic regional perfusion. Also some general considerations in all DC liver transplant related to fibrinolytic therapy, the timing of heparinization, and the cold preservation solution. Finally, I'll give a brief comment on the use of DCD after euthanasia. So again, to start, functional warm ischemia in DCD was the focus of Working Group 1 in Venice. The definition of functional warm ischemia is the period of significant hypoperfusion following the withdrawal of life support therapy and ending at the initiation of preservation maneuvers. There is no universal definition, however, for the start or the onset of functional warm ischemia. Working Group 1 performed an extensive evaluation of different studies and definitions and came up with the following recommendations. Functional donor warm ischemia they considered to be of greater utility than total donor warm ischemia to assessing the risk of liver graft loss. The start of functional donor warm ischemia they defined, based on their research, as the time point where central oxygen saturation falls below 80% and or the mean arterial pressure falls below 60 millimeters of mercury. They also suggest that further prospective data collection is needed to acquire evidence to create more solid recommendations in this regard. If anyone has any further interest in evaluating how they came to these conclusions, I would refer them to this group's upcoming publication in Transplantation. Moving on to procurement surgery in DCD, supradrop recovery is the typical technique that's still used in most parts of the world to recover DC livers. In this regard, location of the withdrawal of life support therapy appears to be a relevant factor in recovering livers. There is no robust data supporting a preferential location for the withdrawal of life support therapy, be in the ICU or the operating theater. One meta-analysis from the United States did suggest that withdrawal in the ICU was associated with higher odds of graft loss relative to DBD donors versus withdrawal in the operating theater. Though this study was somewhat criticized in terms of its methodology, it is true that withdrawal in the operating theater logically reduces time and stress associated with donor transfer, preparation, and preservation, during which injury may occur. So we provide the guidelines that in the absence of contraindications and in countries or settings where it is legally permitted, withdrawal of life support therapy may be preferentially performed in the operating room. In terms of the form of preservation, there are typically two options that are used, aortic only versus dual vessel preservation. Aortic only preservation is obviously achieved faster than dual vessel preservation, though there are no specific studies evaluating single versus dual vessel preservation in controlled DCD. There is some evidence from the context of DBD using extended criteria grafts that dual preservation does offer benefits in terms of graft survival. This study from Italy and the other more recent study from Australia and New Zealand demonstrating improved graft outcomes with dual preservation, and in the Australia study, in particular when extended criteria grafts were evaluated. So we provide the guidance that dual preservation appears to offer improved results versus aorta-only preservation using DBD livers, in particular those that are at higher risk or extended criteria. However, since establishing dual as opposed to aorta-only preservation is not innocuous and may lead to extended donor warm ischemia in DCD, it may be preferable to perform additional portal preservation subsequent to the onset of aortic preservation. It's also been seen in recent years that the donor hepatectomy time is a relevant issue in all liver transplantation and DCD in particular. This is the period between the onset of cold preservation and the removal of the organ from the donor's body. And it's been seen that while the temperature drops dramatically upon the onset of cold preservation, it doesn't really reach the goal 0 to 4 degrees Celsius until the liver is actually outside the body and in cold storage. The relevance of this, the extending the donor hepatectomy time, was first seen in a study published by Ina Jochmans from Eurotransplant in 2019, where it was seen that every 10-minute increase in donor hepatectomy time increased the risk of graft loss, in particular in DCD livers. And so we provide the guidance that there is now sufficient evidence supporting the importance of a short donor hepatectomy time during DCD liver retrieval, and donor hepatectomy time should be kept as short as possible, at most 60 minutes from the start of cold preservation, this obviously requiring the use of experienced donor surgeons to achieve this goal. Now, normothermic regional perfusion was a technique that was first applied in the context of uncontrolled DC liver transplantation to restore the flow of oxygenated blood to abdominal organs following the declaration of death and without any intervening period of cold preservation. It's now been more recently applied in the context of controlled DCD. And in controlled DCD, cannulation for the establishment of NRP can actually be performed at different time points. These time points are largely dictated by law, whether it's done ante-mortem or post-mortem. Obviously, post-mortem cannulation does prolong donor worm ischemia, but to date, there's no evidence that this has any impact on outcomes because subsequently there's reperfusion of the graft with NRP. This table is actually taken from some work that was done in ESOT. However, I think it's relevant to these statements here. So I'm going to present some results from what's being done in Europe regarding ante-mortem interventions, and more specifically cannulation. So there are 2 countries in Europe, if you want to consider the UK as part of Europe, that do not allow any ante-mortem interventions in DC, which include both heparinization and vessel access. France, Italy, and Norway, where NRP is performed in all cases of DC liver transplantation, heparin can be given prior to or during withdrawal, and guide wires are actually used to access femoral vessels and have them localized for subsequent postmortem cannulation. Finally, in Belgium and Spain, heparin can be given prior to withdrawal of life support therapy, and some form of cannulation can be performed in accordance with donor hospital policy. So these are the only countries where ante-mortem cannulation is allowed. We provide the comments that ante-mortem and postmortem cannulation are associated with good outcomes in controlled DC liver transplantation using NRP, and timing and approach to cannulation should really adapt to local rules and legislation, given that there's no clear evidence that timing of cannulation impacts outcomes. What are the outcomes of CDC liver transplantation using NRP? Well, there's an increasing body of evidence of studies being published from different countries, in particular in Europe. There's one study from the United States, which is a little bit older, a small case series. But in general, most studies are coming out of Europe describing the use of NRP in controlled DCD. Obviously, looking at this table, it's clear that donors of greater age are being used more frequently with NRP, and some with even extended donor worm ischemia times. The overall rates of biliary complications are reasonable, relatively low in most series, and ITBL or ischemic type ischemic cholangiopathy is also pretty low, in some cases non-existent, and graft survival appears to be very good. So at this point, we can provide the comment that abdominal NRP appears to be safe and does not lead to any increase in organ loss or adverse patient outcomes. What is the ideal duration of normothermic regional perfusion? Well, there's some experimental evidence suggesting that even with half an hour of NRP after an extended period of cardiac arrest, energy substrates are completely restored. The second study that I have here from Kern-Forn and a group in France is actually kidney transplantation, but it evaluated different lengths of regional perfusion, found that with 2 up to 4 hours, cytoprotective mechanisms were enacted. However, beyond 4 hours, some of these mechanisms actually deteriorated. Returning to work done in ESOT in Europe, the typical length of NRP performed in different European countries ranges from 1 hour to 4 hours, with general preference for 2 hours, we provide the recommendation that postmortem NRP should be run for at least 1 hour and at most 4 hours. This is pretty much consensus recommendation, but it does to be, it's what's being done in most countries at this point. One of the main advantages of NRP after the declaration of death and using it prior to organ recovery is that it allows for a manner to assess the impact of warm ischemia on graft quality and the viability of the liver before it's actually recovered for transplantation. We've seen this primarily through the successful transplantation of uncontrolled DC livers, which generally suffer extended periods of donor warm ischemia lasting up to 2 to 2.5 hours. And different parameters can be used during NRP to evaluate the impact of this ischemic injury on the grafts and organ viability. Obviously, the flow of blood through the abdomen in general and the liver in particular. Transaminases are generally what are focused on to evaluate liver injury. If the transaminase trend during NRP is stable or only slightly increasing, that's a good indicator. Lactate generally needs to be going down to indicate viability, that there's active lactate clearance by the liver. Similar to ex situ machine perfusion, bile production and quality can also be evaluated during NRP. And obviously the macroscopic aspect of the liver and microscopic findings can be used to assess liver viability. So we comment then that livers from DC donors with functional warm ischemia times that are extended, greater than 30 minutes, subsequently recovered with postmortem NRP may be considered for transplantation as long as the evolution of relevant parameters during NRP is adequate. And these parameters are typically centralized on lactate and liver enzymes, which are the most useful components to date for liver assessment. The transaminase evolution in particular is relevant, and it should ideally be stable. This appears to be more relevant in assessing liver viability than the absolute values that are used. Moving on to general considerations in controlled DC liver transplantation and recovery and the use of adjuncts. Fibrinolytic therapy was considered a useful adjunct many years ago based on the theory that during hypoperfusion and arrest in the donor, small clots might actually be being formed in the peribiliary arterial plexus, which cause ongoing ischemia following graft reperfusion, and that by using fibrinolysis, we might actually be able to lyse these clots and improve the outcomes with these grafts. This theory seems to make sense on many levels, but it's also true that many studies have been done in the context of shock and in cardiac arrest and death, where it's been seen that endogenous fibrinolytic mechanisms are actually upregulated in these settings. So this kind of goes against the theory of fibrinolysis. Nonetheless, several studies have been performed, most of them retrospective, evaluating the use of TPA in particular in controlled DC liver transplantation. Most of these studies were being done in North America. They did claim in general improvements in biliary complication rates using TPA, though it's important to comment that most of the grafts with TPA were recovered in more recent eras, being compared to historical controls. The controls typically came for older donors with longer warm ischemia times, and sometimes even longer cold ischemia times. So these studies had significant sources of bias. If anything, these studies, what they demonstrated is that with better patient and graft selection, results could be improved considerably using DC livers. There was one additional study from the Netherlands that also evaluated the use of urokinase in DC liver transplant and didn't demonstrate any benefit. It's interesting to note that the first group that proposed the use of TPA, at least in the literature from the Cleveland Clinic, performed a randomized prospective study that actually failed to demonstrate a preventative effect of TPA for IC or ITBL. And so the Cleveland Clinic group, which was again the first to propose this strategy, actually abandoned their TPA protocol several years ago. Based on this evidence in these studies, we provide the comment that based on a lack of evidence in support of improved outcomes and even a risk for hemorrhagic complications in recipients, fibrinolytic agents should be avoided in DCD liver transplantation. What about heparin? So heparin is another issue that's been addressed in DC liver transplantation. Does the timing of its administration make a difference? Again, timing is typically dictated by law in the European countries and in North America, some allowing for antemortem heparin administration, others not. There's been some study on this from the United States. There was a meta-analysis published in 2016 evaluating studies primarily including patients transplanted before 2010. It did claim an increased risk of PNF, of primary non-infection, for grafts that were not recovered with heparin. A more recent analysis of the UNOS data comparing almost 5,000 controlled DCD livers recovered with antemortem heparin versus almost 600 without did claim improved graft survival when heparin was used. However, those without came from older donors with longer cold ischemia. There were more retransplants, and they were typically transplanted from an earlier era. Nonetheless, the use of heparin in DC donors is relatively innocuous, and so we provide the guidance that, given its low risk profile and its potential for achieving cytoprotective effects, heparin should be given prior to withdrawal of life support therapy in DCD in the absence of any overt contraindications, such as intracranial hemorrhage, and obviously in countries or settings where it is legally permissible to do so. Finally, cold preservations are another topic that have been evaluated to improve outcomes in DCD. Based on that same theory that small clots are being formed in the peribiliary arterial plexus, it was theorized that less viscous solutions, such as HTK, might better wash out the peribiliary plexus in DC grafts. However, this theory was not borne out in several subsequent studies. This is a study from UNOS that was published in 2009, whereby it was clearly seen that HTK used in DCD grafts led to increased risk of graft loss, in particular when cold ischemia times were prolonged. This data was further supported by a study of the ELTR, the European Liver Transplant Registry, published in 2015, which demonstrated inferior post-transplant results with HTK. These results were particularly deleterious when cold ischemia times were prolonged, in particular above 12 hours. And even subsequent propensity analysis of this database confirmed the finding that HTK appeared to lead to inferior graft outcomes in DCD and when cold ischemia times were prolonged. So we provide the comment that the cold preservation solution HTK should be avoided in DC livers in cases where cold ischemia is estimated to be greater than 8 hours. As a final comment, DC after euthanasia is a technique that's being used in a couple of European countries, in the Netherlands and in Belgium. This recent report from both countries evaluating controlled type 3 DC liver transplants and comparing those with the DC after euthanasia did not find any difference in graft or patient survival using DC livers after euthanasia. So we provide the comment that category 5 DC liver transplantation does to date appear to offer results comparable to those of category 3 controlled DCD, and the use of livers arising through this process can be explored further. So I presented a lot of information. I'm not going to summarize everything out of interest for time. There's plenty of opportunity now to answer questions, but I would like to refer everyone to our recent publication in Transplantation, where they can see all of the different analyses that were performed and how we actually came up with those recommendations. Thank you very much, and I'm more than happy to answer your questions now.
Thank you very much, Emilia, for this very nice presentation. We do not have questions from the public yet, so I would like to ask everyone to ask their question in the question and answer box. I have a question for you, Emilia. The procurement of DCD grafts is very different as from a DBD graft and is considered more difficult as well. What is your opinion on how much experience should a procurement surgeon have to be independent for a DCD procurement?
Yeah, I think that's an excellent question. That's actually one of the issues that you also addressed in your paper, I know. Going along the lines of the donor hepatectomy time, I think the experience of the surgeon is highly relevant, whether you're using either super rapid recovery or even NRP. NRP has its peculiarities as well, so I think it's important for DC programs, and especially DC programs that are just starting, to have experienced donor surgeons and more senior surgeons as opposed to junior staff. And that's been supported by the multiple studies that have looked at donor hepatectomy time beyond the study from Rena Jockmans.
Mm-hmm. And another question. You've also do the uncontrolled DCD in Spain. How much is like uncontrolled DCD and controlled DCD? What you do there now in your country?
Well, right now, since COVID, we're not doing uncontrolled right now because of the issues surrounding the testing primarily. Before COVID, to be quite honest, with the advent of controlled DCD in Spain and the success of NRP and controlled DCD and expanding the number of donors, there really wasn't and hasn't been much of an issue of lack of grafts. And so there's been actually many centers have reduced their waiting lists considerably with controlled DCD donors. And there's probably more of a tendency to be a little bit less risk averse and going to the extremes of looking for uncontrolled DCD. We continue to do it in my center primarily to keep getting kidneys. And occasionally there'd be a liver that was good enough to use. But quite frankly, when Spain started doing controlled DCD, uncontrolled DCD has been much less necessary, and people are now more conservative in their selection of those relatively high-risk grafts.
Okay, thank you. There's one question again from Dr. Yassem. He's saying, thank you, Amelia. Apart from the recent paper from Dr. Acali from Italy, is there any correlations between functional warm ischemia time more than 30 minutes and ischemia cardiomyopathy? I think he's also referring to the paper where they use NRP and combined with hypothermic machine perfusion. So in cases of long donor warm ischemia time, your thought on that?
I think that maybe the question is going the way of extended functional warm. For the most part, for super rapid recovery, the general recommendation is to avoid livers with functional warm ischemia greater than 30 minutes, and that's, I guess, depends on how risky you want to be. With NRP, we, based on our experience with uncontrolled, we've kind of extrapolated that, yes, you could potentially recover livers and transplant them after a functional warm time of greater than 30 minutes. I have to be honest, in Spain, given the fact that we can give, in other countries in Europe, it depends. I think it depends a lot on your practices of sedation and analgesia in withdraw, because there's a big variation throughout countries in terms of warm ischemia times. We don't see, quite frankly, a lot of extended functional warm ischemia times beyond 30 minutes. It's not that we're avoiding them, it's that we're not even getting to that point, because in Spain, given that this is withdrawal of life support therapy, it's allowed to give some sedation and some analgesia at that point the patient during withdrawal. So withdrawal times are not extended as they would be perhaps in, say, the UK or the Netherlands, where no sedation or analgesia are allowed. So I can't give a good answer as to whether or not in controlled DCD with NRP, functional warm times beyond 30 minutes can offer acceptable grafts from that context, because we haven't seen a lot of them. And I think the only information that we do have is that with uncontrolled DCD with warm times of up to 2.5 hours, yes, we have successfully transplanted some livers, but there's no direct evidence to support that.
There's another question from Dr. Surendra Kumar. He's asking, what is the role from inside to hypothermic perfusion? Because we have NRP is normally, of course, normothermic, and the hypothermic is more ex situ.
So
you know any data on that?
Total body, that's probably going. That's the concept of total body cooling, because really, when you do hypothermically, you don't have to necessarily exclude the rest of the body. It was done. It was done at the outset when we started doing NRP in Spain. It was compared total body cooling to NRP, to even chest and abdominal compressions to maintain flow during evaluation of uncontrolled DCD. The results aren't robust, but it was found to be highly superior, the use of normothermic regional perfusion to both total body cooling and abdominal and chest compression. So that's largely been abandoned. No, I don't think anyone really is much doing any hypothermic perfusion, either regional or total body cooling. There are some reports from some groups using kidneys, but nothing in the liver. So I can't give you any particular reason other than the fact that that's how it's evolved, and the initial experiences weren't great, so people stopped using hyperthermic perfusion.
Thank you. Then we have another question from Alejandro Rosano. Great talk, Amelia. Thank you. What is the structure in the ICU team to best participate in this very high challenging programs and the interactions with the OR team, and also mainly for nurses?
In terms of NRP, if that's what I think one of the main issues with using NRP and controlled DCD is that the surgical team really comes in at the end. There's really no, I mean, the decision to withdraw is independent of anything related to transplant, as it is without even NRP. And then the teams declaring death and performing the withdrawal are completely independent from any transplant team. The location of withdrawal with NRP is relevant. I think most countries performing post-mortem cannulation, which is pretty much all countries that are doing NRP, do it in the OR because of time concerns. Though I know that some, I think actually in France, where guide wires can be placed, they do withdraw in the ICU. But I think that probably coordination, yes, but the most important thing is to maintain independence of the medical teams, the withdrawal team, and the surgical team, to not kind of blur the ethical lines there.
I have another question for you. Andrea stated in her presentation that the recommendation of the ILTS is for a maximum of cold ischemia for 8 hours in DCD with the super rapid retrieval technique. Do you have any thought on that in NRP? Because of course you have NRP and then cold ischemia, and we have no assessment of the graft afterwards. But you suggest it could be longer, or do you know any data on that?
In terms of the cold time, I mean, quite frankly, and it's not level 1 evidence, but the basic sensation of anyone working in DCD with NRP is that it's about the same as a DBD liver. So once you have the and again, obviously with I guess a functional warm ischemia, that's probably going to be less than 30 minutes, which is the experience in most centers. You want to limit cold time, obviously, but I guess there's not so much of a concern as there would be with super rapid recovery. We do have some assessment of the liver from the NRP period, where you can look at lactate clearance and transaminases, even bile production, bile quality, if that's being done. But I guess we didn't put that recommendation because it's essentially the same as any DBD liver. Yes, you want to get in as quick as possible, but to put a limit of 8 hours didn't really seem necessary.
Okay, thank you. I have one last question. So we have just on hypothermic machine perfusion, we had the results of the DHOPE trial, and the HOPE trial is coming up as well. Is there any trial a moment going on for NRP?
That's a great question. No, there's no random. As far as I know, in the countries that are using NRP at a high level, no, because actually right now in 3 countries in Europe and Norway, if they're doing much, France and Italy, NRP is required by law. So if there's a controlled DCD, they have to recover it with NRP. In Spain, it's not required by law, but it's going to be incredibly hard to convince anyone to go back to super rapid recovery. When we started here, it was split. There was actually more teams doing super rapid recovery and many fewer doing NRP. But over time, that has completely switched to the point now where all teams in Spain are doing NRP. And it's not based on high-level evidence. It's based on the experience and the issues that came along with performing super rapid recovery, and the sensation that everyone had that NRP just works a whole lot better. So no, there's no study in Spain, and it would be incredibly hard to convince anyone to do it. I guess I'd encourage maybe Wojciech or someone from the Netherlands or the UK to do it so that we can have level 1 evidence, but I can't convince anyone here to do that. So
yeah, or that we have like a comparison of hypothermic machine perfusion NRP, but that's probably for later.
I mean, regarding the comparisons, they're not competing technologies, so you can actually use both, and that's what's being done a lot in Italy. So and apart from the fact that NRP also recovers the kidneys, the pancreas, and in some cases now the heart. So its benefits, it's hard to really evaluate how you would how you would tailor a study in that regard, because the benefits don't just go to one organ, they go to multiple organs.
Yeah, in fact, if I may comment, we plan to do it this kind of trial comparison NRP with other techniques in the Netherlands. But as far as I remember, there is also one trial in France that compares use NRP with the historic cohort of NMP from the UK. But the data are not published yet, as far as I know. So that's the only one.
Okay, thank you. Thank you, Emilia. I think we can go to our third presentation now. Okay.
Okay, so the third presentation, the last presentation, is given by Christopher Kroom. Christopher is an associate professor of surgery at Mayo Clinic, Florida. He completed his surgical residency at the University of Western Ontario in Canada. He also graduated in epidemiology and statistics from Harvard University, and he finished a research fellowship in Beth Israel Diaconus Medical Center in Boston. He subsequently completed abdominal transplant fellowship at the University of Western Ontario and HBP surgery fellowship in Mayo Clinic in Rochester. He is mostly interested in donation after circulatory death in liver transplantation, donor liver status, and also ischemic perfusion injury. And he will talk how to improve outcomes of DCD liver transplantation. Christopher, the floor is yours.
Thank you very much to the ILTS as well as the organizers of the DCD Consensus Conference for involving me in this session. I will be discussing some of the statements that were made from the Consensus Conference related to outcomes following DCD liver transplantation. In order to improve outcomes, it's first important to identify what outcomes are relevant. While there has been some variability in the literature, many studies have suggested DCD liver transplantation is associated with an increased risk of early allograft dysfunction, biliary complications, non-biliary complications such as acute kidney injury, post-reperfusion syndrome or hepatic artery thrombosis, as well as graft failure. And it's really important to identify, classify, and predict these events. One of the groups from the Consensus Conference was tasked with looking at early allograft dysfunction, and so I will overview some of their findings in the next few slides. Early allograft dysfunction defines the inability of the transplanted liver to support both hepatic metabolic and synthetic function. Having a good model of EAD is important for several reasons. The first being stratification of graft failure risk for those patients that may need emergent retransplantation. The second is really as a surrogate outcome measure, and that can be very useful for studies comparing different effects on the graft or other interventions. To make this point, the Olthoff definition of early allograft dysfunction has been used as the primary outcome measure for several machine perfusion trials. The Consensus Conference felt that the ideal early allograft dysfunction model should have the following qualities. It should be simple to calculate, based on objective instead of subjective parameters, correlate with outcomes such as graft survival or patient survival, be associated with known risk factors for poor outcome, be dynamic as opposed to static in one particular time point, and be reproducible. This slide highlights some of the more commonly discussed models of early allograft dysfunction, as well as showing how they are calculated and depicting their advantages and disadvantages based on the factors described in the previous slide. One of the earlier models had some subjective measures such as hepatic encephalopathy, and therefore there were some disadvantages with that. One of the more commonly used definitions, the Olthoff definition, has many advantages, including being simple to calculate and being widely validated. One of the disadvantages, perhaps, is it cannot be calculated until postoperative day number 7. The model of early allograft function score is a similar score using similar characteristics, however, can be calculated on postoperative day number 3. The L-graft definition was an interesting one. It does have a lot more complicated mathematics involved with it, and therefore it's somewhat more difficult to calculate and has not been externally validated to a large degree. Finally, the maximal direction and reduction of liver function test score is a dynamic one, which has that advantage, but still lacks some external validation. One of the difficulties with using early allograft dysfunction following DCD liver transplantation is there's been very few studies that have specifically looked at these definitions in DCD transplant populations. This is one of the larger studies that looked at the ILTS definition, and they found about a 40% rate of EAD following DCD liver transplantation. Both patient and graft survival were lower in those that developed EAD. However, there was no correlation between EAD and ischemic cholangiopathy or non-anastomotic biliary strictures. Patients that met the definition of EAD due to the AST or ALT parameters really only had a slightly decrease in survival at 6 months and 1 year, suggesting that in this population, that parameter may not be as predictive as the others. However, patients who did meet the definition due to the INR, or total bilirubin, on day 7 did have significantly worse graft and patient survival. The following are the conclusions and recommendations of the consensus committee with regards to early allograft dysfunction. A universally accepted definition of EAD is not available. The ILTS definition is currently the most accepted, though there has been little validation of this and other EAD models, specifically in the DCD liver transplant population. Available EAD models evaluate surrogate markers of graft function in the early post-transplant period, which is a consequence of donor, recipient, and perioperative factors, and no model captures the contribution of each of these variables to the development of EAD. The ILTS recommends that the future models of EAD take into account the dynamic nature of early allograft function, and specific validation among DCD liver transplants is also recommended. Moving from early allograft dysfunction to biliary complications, the consensus committee felt overall rates of biliary complications were not significantly different from DBD benchmark goals of around 28%. However, when you look at studies comparing DBD versus DCD liver transplantation, most studies would suggest that rates of ischemic cholangiopathy are slightly higher in the DCD population. Therefore, despite all the improvements with DCD liver transplantation over time, ischemic cholangiopathy does continue to be its Achilles heel. This is data from a multi-center study looking at ischemic cholangiopathy following DCD liver transplantation that's currently in press. This study suggests that there are several different types of ischemic cholangiopathy that behave differently. The first two groups were diffuse necrosis and multifocal progressive. These patients had frequent hospital admissions for cholangitis in the first year following the transplant, were largely stent dependent, and almost universally required retransplantation. Other patients were in the confluence dominant group. They could be managed with multiple stents, but frequently recovered and often did not require retransplantation. Finally, a minor form group did have radiologic abnormalities consistent with ischemic cholangiopathy, however, really never needed any stent placement and ultimately did not require retransplantation. When you look at the four groups, you can see they separated quite well with graft survival. Patients in the diffuse necrosis group did very poorly. Patients in the multifocal progressive group had a gradual loss of grafts, whereas the confluence dominant and minor form groups really both did exceptionally well and had graft survival above 75% at 5 years. When looking at non-biliary complications, one can look at the box in the upper portion of the screen and see that there are variable rates based on various studies looking at DCD liver transplantation. With post-reperfusion syndrome, there are mixed results showing either a slightly higher or equivalent rate compared to DBD. With primary non-function, multiple studies have suggested rates may be slightly higher than with DBD transplantation. Acute kidney injury, there's really again mixed results of either slightly higher or equivalent rates compared to DBD. And finally, with hepatic artery thrombosis, rates really seem consistently low and were really within the range of those seen with DBD liver transplantation. With regards to postoperative complications following DCD liver transplantation, the recommendations of the consensus conference were the following. the ILTS suggests that unique benchmarks for best available outcomes in DCD liver transplantation are established. It is recommended that these benchmarks are specific for organ recovery method used, i.e. standard recovery versus normothermic regional perfusion. And currently there is a multi-center DCD benchmark study that is under review, so hopefully we'll have some data coming out on this in the near future. The following lists strategies that have been employed in clinical practice to improve DCD liver transplant outcomes. My colleagues have already discussed some of these issues, such as donor and recipient selection in the previous talks. Therefore, I'm only going to mention the following 3 concepts that are highlighted in red. As you can see from the table, many of these strategies have data to support them, while others are really largely based on expert opinion alone. Additional back table flush is a relatively straightforward concept. However, there has been one study that showed that additional flush may minimize ischemic cholangiopathy. Our center is very adamant about this, as are many others. We do a pressurized flush of the liver on the back table until the effluent is completely clear, so there's no signs of clot or blood within the effluent whatsoever. This may take several liters of flush in order to achieve this, but I really think this is an important component in terms of getting all of the blood out of the liver. Another potential intervention for which there is biologic plausibility, but very little data supporting it, is the use of N-acetylcysteine. This is a rich source of sulfhydryl groups that are important for replenishing glutathione stores, and glutathione acts as a free radical scavenger to decrease damage caused by toxic free radicals. Given that the mechanisms of ischemic reperfusion injury with DCD liver transplantation involve reactive oxygen species and oxidative stress, there may be a theoretical benefit to NAC utilization with DCD liver transplantation. Our group uses a bolus of 150 milligrams per kilo given over 1 hour prior to reperfusion of the organ, followed by an infusion of 150 milligrams per kilo given over 72 hours following the transplantation. While no studies exist describing NAC specifically in the use of DCD liver transplantation, there are some that have looked at this in other settings involving DBDs. So next I'm going to talk about some machine perfusion strategies. This is obviously a whole topic unto itself, and some of this has been covered in my previous colleagues' talks. Really, machine perfusion can be broken down into 3 different strategies: normothermic regional perfusion, hypothermic machine perfusion, and ex vivo normothermic machine perfusion. Well, there was a group specifically at the consensus conference tasked with looking at the use of machine perfusion with DCD liver transplantation. There have been multiple trials that have come out recently, and therefore the consensus statements for that topic are not ready for publication at this time. I will discuss some of the larger randomized controlled trials, including some of them that have come out recently, and just kind of briefly give an overview of those. So the OrganOx system, I think we're all familiar with this trial, was one of the first large RCTs, looked at 170 patients undergoing normothermic machine perfusion compared to 164 with cold storage. 37% of that population was DCDs, and their primary outcome measure was the peak AST during the first 7 days after transplant. What they found was that this was reduced by about 50% in those livers that underwent normothermic machine perfusion. The odds of early allograft dysfunction was 75% lower in the normothermic machine perfusion arm, and there was no significant difference in bile duct complications or graft survival between the groups. More recently, the data from the OCS Liver Protect trial has been released, although there is not an actual publication at this time. This study had 155 donor livers, including both DBD and DCDs that were instrumented on the OCS machine. 152 of these were ultimately transplanted, so that had about a 98% utilization rate. The primary endpoint for them was early allograft dysfunction using the OLTOF definition, and what they found was that those pumped livers had a rate of about 17.3% compared to about 30.5% in the control group. And that was consistent both across DBD and DCD donors. Secondary endpoints, they had near physiologic functioning of the liver while it was on the machine. Patient survival at 30 days post-transplant was high and non-inferior to the control, so 99.3 in OCS versus 99.3 in the control group. Interestingly, in this study, they did show a lower rate of ischemic cholangiopathy, being 1.4% in the OCS group compared to 8.5% in the control group. So it'll be interesting to see further findings from this group. Just recently, this study was published in the New England Journal of Medicine, and it looked at DHOPE, or hypothermic machine perfusion, was a randomized control trial looking at 78 patients undergoing DHOPE compared to 78 patients having cold storage. This study is very relevant because all of the donors were DCD donors, and their primary endpoint was looking at non-anastomotic biliary strictures or ischemic cholangiopathy. What they found was that these occurred in 6% of patients in the machine perfusion group compared to 18% of patients in the control group. And you can see the hazards there of developing non-anastomotic biliary strictures in the image to the right. Secondary endpoints, post-reperfusion syndrome was lower in the machine perfusion group, as was early allograft dysfunction. So again, some very interesting findings in specifically DCD population. So that's the end of my talk and my summary of the consensus guidelines. We look forward to further discussion on these issues in the audience involvement portion of this session. Thank you very much.
Thank you very much, Christopher. Excellent talk and excellent summary. There are so far no questions, so I would start the discussion. Well, ischemic cholangiopathy, of course, Achilles heel. But the question is what you showed on your slide. Do we talk the same language describing the ischemic cholangiopathy? Because basically, for me, ischemic cholangiopathy is relevant if you need to do any procedures, or transplantation, or progressive biliary stenting. You showed clearly that there are some cases which doesn't need any intervention. Do we have to score them as really ischemic cholangiopathy?
Yeah, I think that's a good question. I mean, again, it's all about semantics or how you use the definition. We routinely place a biliary catheter through the donor cystic duct in all of our DCD donors. So we shoot a day 21 cholangiogram, and we've done that for 20 years. So we have pretty good images where we've been able to sort of see progressions, et cetera. Sometimes you'll have patients where on day 21 or early on, you're starting to see some of these changes and you don't know exactly how it's going to progress. And yeah, I mean, to your point, some of them, have some mild issues there, which really doesn't turn into anything. Others, you'll see definite evidence of ischemic cholangiopathy. The ALK phos is up. You're doing ERCPs to clean debris out of the ducts, et cetera. But it really doesn't extend into the periphery. And a lot of those patients don't need to be retransplanted and can be managed okay. Those ones are definitely symptomatic and definitely, having issues. But I think the, when you see the pattern that's the peripheral pruning of ducts, et cetera, and they're starting to get cholestatic, et cetera, in those cases, I think they're rarely salvageable. So yeah, to your point, I don't know, maybe it's time to have a better definition and maybe a grading of the definition or something. So I think, that's been part of the problem when you look at publications and people claim different rates of ischemic cholangiopathy. What are we talking about? Are we talking about the same thing? So yeah, I think that's a great point.
Okay, thank you. I have a question from Dr. Mulligan. Based on the last two talks, there is concern over the use of HTK for preservation of DCD grafts, but there is an advantage due to the less viscosity if ischemia times is less than 6 hours. What is, I think that's for both, for Amelia and for you.
Yeah, Amelia, you want to go first, or do you want me to go? I can go. Yeah, my comment on it, I mean, we usually use UW. That's just kind of standard of what we do. I'm familiar with the studies. I was in a center previously that believed HTK was better with the viscosity issue. I don't know. I'm not. I think the data is the data. I think we're familiar with it, but I think in the U.S. largely people use UW. I don't know, Amelia, if you want to comment.
I think that the reason HTK was first used, the theory was that a less viscous solution would wash out these supposed tiny clots. And if we want to evaluate a potential benefit, we have to really question whether that theory of tiny clots is real. There's a lot of literature, not from the transplant setting, but from shock and even studies from Dr. Porte's group on clotting. But when people go into states of shock and when they die, endogenous fibrinolytic mechanisms are upregulated in the body. So really clot, as far as we've seen, clot is not forming. Now there's a new theory now that there's an endothelial injury, that the clot isn't formed so much in the donor as it is post-reperfusion in the recipient, which then questions whether we should go back to the theory of fibrinolysis in another context. But the reality is that when we give HTK, the preservation solution, there's limited evidence. There's really no evidence to suggest that we're washing out these little clots. And so HTK is less viscous because it doesn't have a colloid, and the disadvantage of not having a colloid is that you get significant issues with edema and other problems when the ischemia time is prolonged. I always found it interesting that of all the organs, the group that the organ that consistently doesn't use colloid solutions is the heart. That's where custodial was designed to be used, in the heart. And it's the one organ where the ischemia times are always the shortest, and you have the cardiac surgeons who are rushing to get the heart in because they don't use colloid-containing solutions. But all the other organs that use colloid-containing solutions, the abdominal organs with UW, IGL, in the chest with Perfidex, the preservation times can be extended. So I really don't think that at a basic science level, HTK has some significant disadvantages. And I think, yeah, if you use it for short periods, maybe it's fine. But at a conceptual level, it's not the ideal solution.
I have a next question to Christopher. Thanks for the great talk, Christopher. Besides the ischemic cardiopathy, the other concern is the biliary anastomotic stricture. Do you usually protect the anastomosis with a stent? Is it recommended? It's from Dr. Rossano. You told that you use regular the biliary stenting, but
yeah. So it's actually a pediatric feeding tube that we use. So it's very small in diameter. I think in terms of activating anastomosis, I think it does very little. I mean, I don't think we use it in that setting. It's more just to get the image. So I agree. I think anastomotic strictures, also can obviously be an issue, although much more manageable. The one thing I will say, which is sort of a somewhat unrelated point, but I think, we tend to avoid patients, if possible, that are going to need a RU or that we know are going to need a RU in DCD setting, just so we have easy access to the biliary tree. Obviously, you can, get access even with someone with a RU, but that's just a side point I would make.
Okay, thank you very much. And that's next question also from Dr. Mulligan. Can you comment on the use of TPA for DCD grafts? I think it's also for Amelia, because Amelia talked about the TPA.
I can comment too.
Yeah, but please, Christoph, start with your comment. TPA.
Yeah, I mean, I think with TPA, there's definitely the studies again that were shown that showed better outcomes when they started protocols with TPA. At the same time, all of those programs made multiple other changes, and so their results got better as a result of all of their changes. Was it the TPA? I think you don't know. I think with many things, I talked about NAC, which we use. There's not really data for it. Does it help? I don't know. I think if you start using something and your protocol is good, people usually don't change it. So I don't know. Again, we don't use TPA, and we haven't really had issues with that. But
okay.
Yeah. Aside from the scientific basis, or the lack of a scientific basis for the use of TPA, when we actually did a study here in uncontrolled DCD with very marginal DC livers, And in the recipients, we saw generally problems with fibrinolysis in our recipients with these ischemically damaged grafts. And we were actually we give in all of our uncontrolled DC recipients tranexamic acid. So that actually goes against the whole fibrinolysis idea. I think when you have good quality DCD livers and you're improving other factors, as Chris mentioned, you know, all the studies that have supported the use of TPA have used a historical cohort to compare with, and have also improved their ischemic times and their donor ages and donor selection. So they saw improved results with TPA, but also had multiple, I guess, confounding factors. And the only study that it's not published, but it's mentioned in a report from Hashimoto from the Cleveland Clinic that they did do a prospective trial at the Cleveland Clinic, and they didn't see any benefit. And they actually had probably based on their better selection of patients. Actually, it was not better patient selection, but they had the better results in terms of ITBL in the group without TPA. Not significant, but they did not see any benefit for TPA, obviously. So I personally don't believe that it. I think the evidence doesn't support the use of TPA, but I guess if you have good quality grafts and you don't have an excessive risk of hemorrhagic complications in your recipients, you can consider giving it if you think that that's going to help. But in reality, when grafts are really marginal, there's more hemorrhagic and hemorrhagic complications. The recipients can be a detriment to give TPA.
Okay, I have another question to Dr. Krum. What was the proportion of the various ischemic cardiopathy types in the report mentioned? Particularly interested in those requiring retransplantation. So the group which was retransplant.
What was? I'm sorry. Say the first part of the question.
Yeah. What was the proportions of the various?
Yeah. So the I think the exact numbers. It was probably the most common type was probably the multifocal progressive. So that would sort of be the classic ischemic cholangiopathy that we talked about, where you know, people maybe start day 30 or 40, start having some abnormal lab values and progress. The minor form, we didn't see that commonly. Again, some of that might be some bias because you know, they don't always present. But more recently, we've seen more of the confluence dominant, which really you know, you see abnormalities for sure. In the primary and secondary ducts, and they have sometimes some cholestasis and some casts, but you can usually clear it out. So I think some of it has to do with how risky of grafts you're taking, your warm times, etc. The diffuse necrosis type, that type is basically very early on, almost complete necrosis of the bile ducts, and those patients either get retransplanted or do very, very poorly. So I think if you're really pushing your limits with warm time, you may be more likely to see that. Whereas in a more conservative level, probably the multifocal progressive or confluence dominant are more common.
Thank you. And then last question, because I think we have to conclude slowly our webinar. A great presentation, Chris. How long would you wait before deciding to re-enlist, particularly on patients with progressive peripheral ischemic cholangiopathy? And do you routinely use ursodeoxycholic acid?
Yes, I'll answer the second part first. We routinely use urso, so in all of our IC patients, they would definitely get it. In terms of how early you list, yeah, that's a really tough question. I mean, I think, you know, one of the problems we have in the United States, which I think some people are working on maybe fixing, is we don't really have a good exception pathway for these patients. And so often they languish on the list. I'm sure, you know, we've all seen people with lower MELDs, but that have bad ischemic cholangiopathy and you can't get done. So I think in terms of when you list, I think you have to give at least some time to see if you can manage it and how it's going to progress. You know, when you first see the abnormalities, you don't, unless it's a diffuse necrosis type, you don't really know how much it's going to progress or where they're going to end up. And so I think at least maybe, you know, 4 to 6 months of attempting to address it with ERCP, et cetera. At that point, I think if you're struggling or really not making any progress, then probably it's time to consider it. obviously, there's the exception of the patient that's doing really poorly. Overall, obviously, you don't want to wait until they're too debilitated to get transplanted. So, but I think maybe 4 to 6 months if I was to give a number.
Okay, thank you very much. I think we have to conclude this webinar, and then I will ask Marit to give the last few words.
Yes, thank you. So I would like to thank all the speakers for their great presentations, and also thank you, Wojtek, for joining me in this moderation. So thank you all for attending this webinar. We hope you enjoyed it, and would like to thank Bridge to Life again for their support for already our 4th webinar. And we hope you also join us at the 2021 Virtual International Congress of the ILTS Elite and Like-Age. That will be held from 5th of May until the 8th of May. You can find all the information on the ILTS website. And our SIG will also have a meeting during the conference as well. It's on Wednesday, the 5th. And we hope to see you all there again. Thank you very much. Have a good day, evening.
Thank you very much.
Bye-bye.
Bye-bye.